So what I'd like to do is to get into the topic at hand, which is what I call high-performance medicine, a takeoff of high-performance computing, because it really is the coalescence of markedly improved machine power with the care of human beings. So you may be familiar with what I would view now as a classic book by Danny Kahneman, Thinking Fast and Slow. And the fact is, today in healthcare, we use system one thinking. It's highly reflexive, frequently wrong, and we not only have lots of errors, 5% serious errors of diagnoses in the United States, but we also have an inordinate amount of waste because we do things, whether it be screens and various tests and labs, that are unnecessary. And so what we'd like to do is to change to a medicine that's not fast and shallow, but one that is deep and really understands each human being. We have the tools to do that now, but we haven't really implemented them. And that is what Scott mentioned earlier of ACC, the ability to use the data. Being human is now something we can understand far better than we could just a few years ago. The multiple layers of what information that is the essence of each person. And the whole idea that the data can transform healthcare, which was a cover of The Economist recently. So this is really the main premise, is that all these layers of information, be it the physiology through sensors, the anatomy through scans, the different biologic layers of DNA and protein and metabolites, the microbiome, of course, the epigenome, and the environment, or what is commonly referred to these days as the exposome. If we could have all these layers of information for any given person, we could deliver far better care and prevention. And it's not just a one point along a lifespan or health span. It's many points that need to be assessed. And when I did this review now a number of years ago, I called it From Prewomb to Tomb. And one of my old mentors told me, Eric, you really blew it. You had the wrong title. It should have been From Lust to Dust. I said, you know, you're right. That would have been much more alluring. Now, the other thing that's important to recognize is that the sensor world has been ingenious in terms of capturing data in a person's real world, in their real environment. And that's a different type of medicine than the one-off type of visit that we have today. And we need to take advantage of that data, which of course is now almost every system of physiology of a human being. So what's happening now, it's happening quickly. We have the first AI-approved consumer deep learning algorithm in the US, that is the ability to detect on a smartwatch atrial fibrillation and potentially many other heart rhythm disorders. We also can go well beyond that. The idea that if you have kidney disease and you could diagnose your potassium level through your watch, through the electrocardiogram, is another manifestation of algorithms seeing things that humans can't see. And this is soon to be out there in the US, ready any time to be approved by the FDA. We now have smart watches that get blood pressure very accurately, such as this one, that I've been testing and been very, very impressed that it can be another way to have a handy blood pressure right on your wrist at any time that you're interested to see. And of course, that comes up at times when you might be in traffic. Of course, that doesn't occur in Auckland. Or if you were having an argument with your spouse. I know I'm the only one that has that problem. But, and by the way, my spouse, Susan, is here with me today, so she can vouch for that. Now, glucose sensing is a big deal because now we're learning that people who are healthy without diabetes have glucose spikes. About 2/3 of people have a varying magnitude of glucose spikes, and we now can learn ways to avoid that if need be. And one of the most striking examples, simple, is a connected inhaler, which in the city of Louisville, Kentucky, led to a 70% reduction of the use of inhaler and a 50% reduction of asthma attacks, just from knowing where hotspots were of poor air quality. So some have been questioning digital medicine's contributions of validated data sets, of being randomized trials or the one non-randomized study in asthma that I just mentioned. It is unequivocal that we have now hard data that digital medicine is advancing the field. And someday we won't even use the term digital because the progress has been remarkable. But what we haven't done yet, largely, is to take that data and have deep learning from it. And so now the idea of having neural networks is, of course, the next big phase. And you're familiar with these. The idea of having data going through layers of neurons, largely dependent on the data itself, rather than the biases of researchers, to get an output, which can be a skin lesion, can be images, can be speech, can be text, so many inputs and so many outputs from this deep learning in healthcare. An excellent review by Andre Esteva from Stanford that just was in the current issue of Nature Medicine that Robin mentioned. What's fascinating is 150 exabytes of medical data in the US alone in the last year, which is about a 50% increase from the prior year. So this is the review that Robin mentioned, and it's when I was asked to do the review by Nature Medicine, I said, I'll only do it if you make it open access. And they said, well, that's hard for us. We can't do that. So we made a deal for 30 days. It'll be open access. So if you haven't downloaded it, you better do it in the next few weeks, because then it will be, if you don't have access through your university, it will not be open access. At any rate, this is something that is across the health span. Just like we talked about with genomics, it's the same thing with AI. Everything from embryo selection and for in vitro fertilization to predicting the likelihood of death in a hospital setting. And it's across every type of clinician, not just doctors and nurses, but paramedics and pharmacists. There is no clinician that would be spared from the impact of AI. So there was a very interesting, well-done documentary by the BBC recently in November. I don't know if you had a chance to see this, but I have a few snippets from it because I think it really is a good treatment of the field. Here's the first of those. So the way I look at this field is it has, as I mentioned, effects across all clinicians and for health systems and for patients or consumers. And I just want to get a little bit deeper into each of these three areas. The first is, I mentioned about the different specialties, and many people think that radiologists are the primary group that has been so far affected, or at least been published upon. But it turns out it's really ophthalmologists. Now, what's fascinating is that if you give international retina specialists a photograph of the retina, and you ask them, is this from a male or a female? The response is 50-50. They can't do any better than that. But through deep learning algorithms, the accuracy of determining sex is 97%. That's pretty astounding. Now, there are other ways to determine gender. I understand that. And this is not exactly clinically a breakthrough. But what it shows you is things that humans can't see, and we still have no idea about how this is possible, because the black box of the algorithm has not been cracked. This comes from a study that was published just almost a year ago from the folks at Google AI and collaborators, and this was one of the most striking aspects of that study. But it's not the only one with respect to eye disorders. And in fact, you can see not only the ability to detect diabetic retinopathy, which is underdiagnosed. At least half of diabetics don't even have screening for retinopathy, and it is a preventable form of blindness, a leading cause of blindness. And that's why it's important to note that the first prospective clinical trial in AI medicine was in diabetic retinopathy. A University of Iowa spin-out company called IDX randomized 900 people, and now the results, they're not perfect. The sensitivity and specificity hovers around 90%, but now the receptionist in a doctor's office can obtain the retinal images and through deep learning algorithm, through cloud-based analytics, the determination of whether there is and what grade of retinopathy can be determined, and this is already out in several centers in the US. But it's not just photos of the retina, it's also optical coherence tomography, and this is one of the most striking studies that's been performed to date at Moorfields Eye Hospital, one of the leading eye centers in the world, in London, with DeepMind. And what they did is they took thousands of these OCT exams and they classified over 50 different eye disorders. But what was striking is they didn't miss one urgent referral. This is retrospective, but remarkably accurate and more accurate than retinal specialists. And so this is a pretty striking study, one of the best retrospective studies that's been performed to date. So in the US, we have radiologists that read 20,000 scans per year, or about 50 to 100 per day. But it's amazing to point out that the false negative rate is about 1 in 4. And of course, there's a false positive rate. There's a lot of lawsuits. Almost a third of radiologists are sued. And we have so many images in the US, way outlier for most anywhere in the world. So the idea that perhaps deep learning in radiology could help, and there already are multiple companies that have FDA-approved algorithms that are entering US hospitals, and they're also, many of these are widely used in other places around the world, particularly in China. The ability to detect things like a pulmonary nodule better than radiologists in this study, a very large study compared to 13 board-certified experienced radiologists. And the ability to detect intracranial hemorrhage with a full explanation of how the algorithm was able to achieve its pretty striking beneficial results, and a prospective arm of the study, of which there have been very few. And here's an example of emergency room doctors who are not very accurate in making the diagnosis of a fracture, a difficult wrist fracture, and this was a study that showed that this algorithm could lead to almost 50% reduction of misinterpretation in the emergency department setting. What's interesting too is in pathology, we have the ability to make the diagnosis of the mutation with deep learning algorithms that pathologists can't see with their human eye. So that is starting to happen, and this, of course, is another real advance. And this is a pretty remarkable study also done by Google AI regarding deep learning for breast cancer metastases. And this was compared to 6 pathologists, and the results were as good as pathologists. But what was particularly noteworthy about the study is that the combination of machine learning of these slides and the pathologists was extraordinary. The accuracy, bringing both together, was quite striking. And similarly, this is with prostate cancer. The fusion of efforts between deep learning and clinicians is a repetitive, important theme. And this goes on. This is from India, being able to diagnose all the different things that could go wrong in the brain by head CT with quite a remarkable accuracy. And I mentioned Estava, who was from Stanford, where they compared 21 board-certified dermatologists for skin cancer, skin cancers, particularly melanoma, and they showed at least as good ability for algorithms to make that diagnosis accurately as the dermatologists at Stanford. Now, particularly interesting study that came out just in this new 25th anniversary issue of Nature Medicine was the one where they took the electrocardiogram and trained it to predict the heart function. That's never been done before, to be able to detect the ejection fraction from an electrocardiogram. This is a real advance because that's a very inexpensive way to grade cardiac function. And it's something, again, that we can't see with our eyes. We can't be trained to see that with our eyes. And one other example, which is particularly noteworthy because gastroenterologists frequently miss small polyps. And now with machine vision, that is starting to go away, that error problem. Now, that's some specialties, but perhaps the most extraordinary thing across the board is the doctor visit. Because a doctor visit today is very much relying on a keyboard and lack of eye contact. And all these companies, some big tech titans and some startups, are all engaged in natural language processing of the conversation that occurs in the visit to then make a note, which is far better than the notes that we have today. And many of them have already gathered quite a bit of momentum. So this is a clip that summarized the status of publications in the field from that BBC broadcast. And that's a problem. That's actually the IDX diabetic retinopathy trial. There's very few peer-reviewed prospective clinical environment studies. So before we get too carried away, I just wanted to point that out, that this is an issue. So let me just run through the other two areas I mentioned. Health systems, which is the ability to do remote monitoring and obviate the need for hospital rooms, no less to eliminate many jobs that can be done just as well by algorithms. The back office operations like coders and billers and scribes and the administrator creep that we've seen over many years, and improving safety in the hospital, preventing falls, promoting hand washing with the right standards. All these things can be done in health systems. We've seen publications now to prevent low oxygen during surgery with machine learning algorithms. We've also seen the ability to treat sepsis much more rationally evidence-based through algorithms such as this AI clinician. We have a lot of predictions so far of almost anything you can think of in healthcare, but they're all over the map. There's no uniform standards. There's lots of methodologic issues. And we're seeing lots of new FDA approvals. These are proprietary algorithms. They haven't largely been published anywhere, and this represents a problem for trust in the medical community. At least in the US, it's certainly an issue. Now, the last area I wanted to just touch on was patients and consumers. I already mentioned the ability to diagnose potassium. The ability to structure a diet that's individualized is in the works. Many other things that are happening. But this whole idea of making a more humane interaction to promote the patient-doctor relationship, the idea that we shouldn't have little girls drawing pictures of their experience at a pediatrician office that looks like this. And the whole idea that we don't want to necessarily rely on Dr. Bot, which has not really been validated at all, but to be able to take the relationship that should be there, the gift of time that can be afforded through these supports through deep learning and machine learning. So the whole idea long-term is to have this virtual medical assistant to take all of one's data, every layer, including the entire medical literature, and to then synthesize that to provide guidance. We'll see that first for things like diabetes and blood pressure, and eventually we'll see that across the board for guiding human health for those people interested. And this review brings together the challenge of these multiple inputs like sensors and genomics and everything else that was mentioned. I've reviewed that this has to be validated. We're short on validation and long on promise. And ultimately, we'd like to see the implementation phase, which really hasn't started except in a few pockets around the world. But certainly, we've seen beginnings of being able to manage, prevent migraine through deep learning, smartphone algorithms, and lots of things about depression. All these different ways to monitor depression through passive things like voice and keyboard interactions. And obviously, depression and mental health is a very important issue where there's underserved by professionals. So the last thing I wanted to point out is the analogy between driverless cars, where we had wild expectations with respect to that they all would be driving around without any driver under any condition. That'll never happen. And just like that, we will never see a doctorless world of healthcare. But we will see support, and we may see some achievement of certain levels along the way for certain conditions. I don't want to review in depth, but we need to have our data. Each person should own their data, and these are the 27 reasons why that's imperative. And if you don't have your data, you're not going to ever have a real virtual medical assistant. There are deep liabilities I'm not going to review. I think you're in touch with them. But things like privacy, security, and the bias, the problems of potentially promoting inequities rather than reducing the problem, these are things that are center stage. So I'll just close with this segment from Hannah Fry, who is an AI mathematician in the UK, how she summed it up. It's not going to be easy, but it's certainly the most exciting time we have in medicine. I'll stop there. Thank you. Thank you, Marty, for your wonder, and the organizers for this fantastic program. Thank you.